Let's move on and keep discussing vasculitis with going to these small vessels. This is where we get granulomatosis with polyangiitis, which previously was called Wegner Granulomatosis. And because Wegner was this kind of person, we no longer like to refer to it as Wegner's granulomatosis. It is now granulomatosis, so there is some sort of granuloma formation, and lots of vessels are involved. So this is a small vessel vasculitis that is described by the presence of a lot of granulomas and a lot of vessels with inflammation. So put it all together, and we know that there's some sort of inflammation going on within our blood vessels and a chronic progression that will eventually lead to the presentation of granulomas. I like to remember Wegner's as something that we inhaled throughout our respiratory tract, which triggered an autoimmune response that causes deposition of antibodies in random foci in vessels that were exposed to whatever we inhaled. So some sort of inhaled agent, some inhaled antigen was taken up and exposed to the upper respiratory tissues. So you are upper respiratory tissues. And this antibody also gets filtered by the kidneys because that's the kidney's job. And that is how there is some sort of renal involvement, because the kidneys filter the blood and these antibodies end up being deposited on the glomerular basal membrane, which again, anytime you deposit antibodies anywhere, you activate complement. So in this situation, we activate complement on the filtration barrier of the kidney, which is the glomerulus, causing damage in the form of a necrotizing glomerulonephritis. So let's look at this image first. This is a CT scan of a patient with Wegner's. There's a great way to think about this, because someone might give you a CT scan. So if you see this upper lobe segment here, this is the left, this is the right, this is a CT scan of your patient. As you can see, there's a huge cavitation. This is because we've caused inflammation in the pulmonary vasculature for so long that we eventually made an incredible amount of granulomas. All of these granulomas came together and formed this huge cavity. So the respiratory tract of these individuals is usually always involved in addition to renal involvement. Remember, just imagine that we damage the mucosa lining the nasopharynx, which means that we get inflammation and bleeding. In addition to the upper respiratory tract, which we said there was some nasopharyngeal involvement, so nasopharynx, because we think it's an inhaled antigen that triggers the autoimmune response, so the nasopharynx, and then you get some sort of hemoptysis because there's also involvement of the alveoli. There's bleeding into the alveoli because there's damage to the pulmonary vasculature. Remember, the pulmonary vasculature surrounds the alveoli. So now we have some nasopharyngeal bleeding and ulceration. Then we have hemoptysis because we're bleeding from our pulmonary vasculature that's being damaged into the alveoli, and then we cough blood up. There's large cavitations in this disease that you can see on CT scan. Renal involvement, again, is due to deposition of anti-protease 3 antibodies in the glomerular basal membrane, causing complement-mediated damage. If you disrupt the integrity of the glomerular filtration barrier, you lose red blood cells into the proximal convoluted tubule, where they will combine with a TAM horse-fall protein and form a red blood cell cast. Now, you can also lose blood and present with hematuria. So, you see that this is a very complex disease, but if you just think about it in the way that we inhaled something through our nasopharynx, so you can see some nasopharyngeal ulcers and bleeding. It also was in the lungs, causing damage to the pulmonary vasculature, and it is filtered out by the kidneys, and this is why we have renal involvement, due to a necrotizing glomerulonephritis presentation. And this is all due to anti-protease 3 antibodies. What is the treatment with this? Well, just like all the other ones, we hit them with steroids, in particular corticosteroids, and if we need to, we can also step it up and get some alkylating agent like cyclophosphamide in the equation. Let's move on to microscopic polyangiitis. Very similar name to what we were just talking about. It is very similar to Wegner's in the fact that it is a presentation of many vessels, and those vessels are inflamed. Can you tell me the name of the antibody that's involved in this disease? Well, this would be perinuclear anti-neutrophil cytoplasmic antibody, or PANCA, for peripheral anti-neutrophil cytoplasmic antibody. And these surround the nucleus, hence the word perinuclear. So here, in your image, you can see that there is a perinuclear illumination on immunofluorescence, because the antibodies are positively charged when you fixate and you stain. Where do you think they will localize? probably around something that's very electronegative, like DNA. So if you imagine DNA is sitting inside the nucleus, and these antibodies will localize to areas of very high electronegative charge because the antibodies prepared are positive. Now, the most common type of perinuclear antibody that we would expect in microscopic polyangiitis is anti-myeloperoxidase. Now, this makes a lot of sense because anti-myeloperoxidase antibodies are made to the myeloperoxidase enzyme of neutrophils. So remember, myeloperoxidase is an enzyme produced by neutrophils. It uses hydrogen peroxide and a chloride anion to produce hypochloric acid or bleach. Now, it is important to understand that it is the P or C in front of the ANCA that only helps you narrow it down to a couple of diseases. The P only tells you that an immunofluorescent staining pattern shows up perinuclearly or around the nucleus, while the C in the C ANCA only tells you that it's cytoplasmic staining, but they're both anti-neutrophil cytoplasmic antibodies. Do not let the confusion that there's two cytoplasmic in the C ANCA component. It is just telling you the distribution of the staining. Both of these antibodies are going to be found in the cytoplasma because they're not allowed to enter the nucleus. These stain around the nucleus as opposed to the cytoplasmic stain a more distributed cytoplasmic pattern. So as you can see in this image, this is the distribution of staining of C ANCA or cytoplasmic anti-neutrophil cytoplasmic antibody. We just said that granulomatous polyangiitis with granulomas or Wegner's also presents with a P ANCA antibody, except that those proteins are targeted against which protein? Proteinase 3. So it can get rather confusing because Henochscholein also has anti-myeloperoxidase antibodies, but the clinical presentation helps us differentiate that. So again, let's review. Microscopic polyangiitis does not have any granulomas in comparison with Wegner's. So microscopic polyangiitis with granulomas is Wegner's. Microscopic polyangiitis does not have any granulomas in comparison with Wegner's. But this presents just like Wegner's because there is a necrotizing vasculitis involving medium-sized vessels in the lung, and the kidneys, and the skin. So that presentation can confuse you. In addition, this is a posse-immune glomerulonephritis because when you stain for myeloperoxidase ANCA antibodies with immunofluorescence, there's very little staining in the kidney biopsy you took. And posse means little or few. Now, the deposition of antibody complexes in the skin compromises the integrity of blood vessels. So, where do you think the red blood cell that should be in a blood vessel will go if we've killed away the vessel wall that contains it? So, red blood cells will leak out into the skin and show up to purpura. Now, purpura describes the color of the red blood cells in the skin. It is palpable because there is inflammation associated with damage to the blood vessel. Now, what's important to remember about this disease? Well, you need to remember that microscopic polyangiitis presents just like Wegner's, which means that there's lung, kidney, and skin involvement. But there is no nasopharyngeal involvement or granulomas. So, Wegner's has nasopharyngeal involvement and granuloma formation. How do you treat this microscopic polyangiitis? Well, just like all the other ones, there's a common trend of corticosteroids. If that doesn't work, then you can go with the big dog of an alkylating agent like cyclophosphamide. Now let's talk about Henochscholein. Henochscholein is also another P ANCA myeloperoxidase mediated vasculitis with a very unique allergic component. So just think about it that way. These patients will have very high IgE levels associated with a small vessel necrotizing vasculitis. In your mind, you should consider Henochscholein of a triad of allergic rhinitis, asthma, and vasculitis. So the excess of IgE can help you remember that there's a prominent eosinophilic component. So E for eosinophil, and there's IgE levels that are elevated. Now, eosinophils can actually infiltrate the myocardium. So these go into the myocardium and release major basic protein. This causes major cytotoxic damage because of direct damage to the myocytes. Now, just like the other necrotizing vasculitides, imagine we are depositing antibodies in the vasculature of the lungs, skin, nerves, the GI tract, and the kidneys. So we expect this to result with some sort of lung infiltration, and there certainly is. So the lungs are damaged. The skin, this is where we get palpable purpura. Damage to the vessels that supply the nerves leads to neuropathy. And this is a particularly high yield segment because you can get wrist or foot drop if we're involving the radial or peroneal nerves. The GI involvement will lead to GI pain, and obviously kidney involvement leads to a glomerulonephritis. So let's look at this image. As you can see in this image, there are an incredibly high amount of inflammatory cells everywhere. Look at all this. It's just blue, 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 blue. We have completely obliterated this lumen as well due to the fibrosis. This is a lumen that's full of red blood cells, which is supposed to be the blood. So this is a cross-section of Churg-Strauss syndrome with a lot of inflammatory cells and eosinophils and obliteration of the lumen of these vessels, in addition to a lot of this fibrotic pink collagen, as you can see in this segment, and a little bit as well in this area. These splash quizzes are so sneaky. What is Berger disease? Remember, Berger disease is a thrombosing vasculitis affecting the small and medium-sized peripheral arteries and veins of heavy smokers. Tobacco is their problem, and that is their treatment. Excellent. Let's move on to Henochscholein Purpura. Think about this disease in one way. Excessive amount of IgA. Why this occurs is not yet fully understood, but I like to conceptualize it, the pathophysiology, in a way that I'm about to tell you. So there's some sort of insulting factor. Usually it's a upper respiratory infection, so a URI. And this stimulates an immune response, and for some reason, the immune system responds by giving excessive amounts of IgA for us. Now, the production of excessive IgA means that we will have lots of this antibody circulating around. Where is it going to go? How about in the microcapillary networks that are prominent in places such as the dermis, the dermal papillae, in our joints, in the GI vasculature, and the glomerulus? The deposition mostly occurs in the venules that drain the capillary network. In your book, it says that there are immune complexes deposited in these areas. Now, remember, to have an immune complex, we need an antibody. So again, we need an antibody bound to an antigen, and complement will later be attached. Now, what is the antibody complex in HSP? Antibody complex is fibrin, IgA, and a C3 complement protein. So we have these complexes depositing in the dermal papillae, the joints, the GI vasculature, and the glomerulus. How are we actually going to have end organ damage due to deposition of these immune complexes? Well, C3 is the bad guy here. It will split into C3a and C3b. We know from that dreadful complement diagram, C3a is a anaphylatoxin. This means that it will cause a dramatic release of histamine and leukocyte chemotaxis. So now we get white blood cells in the equation. Now, what does all this histamine release do? It increases capillary permeability. Increased capillary permeability causes leakage of things across a particularly low flow and low pressure area. Where would that be? How about a post-capillary venule? So if you think about this is a capillary network here. This is the arterial supply, and here's the venous supply. If you have disruption of endothelial cell barriers due to something like histamine, then we have a very large junction due to very high levels of increased capillary permeability. Now we have the extravasation of red blood cells. They can move out across of these leaky junctions into the interstitial tissue. And this makes a lot of sense because inflammatory mediated increased capillary permeability in locations such as the dermal papillae allows extravasation of these red blood cells into the dermis and epidermis. And then the combination of the inflamed area with the red blood cells that leak out leads to the production of palpable purpura, hence the name purpura in the disease. Now, what does the invasion of the vessel wall by leukocytes do? Well, these white blood cells go to the wall and eventually continue this inflammatory response. So it will eventually lead to the accumulation of debris and leukocytes within the wall. and this causes a decreased diameter of the vessel lumen. As you can see, we're adding stuff to the wall due to this abnormal autoimmune response. It's a vasculitis. We're depositing IgA that's excessively made in hard vessels and narrowing the lumen, causing a decreased diameter, which means decreased oxygen delivery to the tissues that are going to be affected, which are the dermal papillae, the joints, the stomach, and the glomerulus. You have a very excruciating, crampy-like abdominal pain with Henochscholein Purpura for this reason. This is the classic presentation for Henochscholein Purpura. As you can see, there's a classic posterior thigh and buttock involvement of these purpura. They're also on the lower extremity and a little bit here on the surfaces of the forearm.